There's been a lot of research examining the relationship between surgical case volume and outcomes. A paper in the October 24th, 2016 issue of JACC Interventions looks at an important clinical setting, operator experience and volume on outcomes after left main PCI. So to talk about this, I'm with Dr. Philippe Genereux, who is director of the Angiographic Core Laboratory at the Cardiovascular Research Foundation, which puts on TCT, and also an interventional cardiologist in Montreal, correct? Now, why were you interested in doing this study? Because this is a great group of patients, so what drove you to get this interest?
Well, first of all, thanks for having me again. It's always a pleasure. But I think what drove me, I got this idea when I was in China, actually, with my friend Zubo. And Zubo has a lot of cases in China, a lot of hospital, a lot of cath lab. And he had a huge database, and I started to talk with him about to look at the level of experience and the volume to see if there's a relationship with complex PCI. Because right now there's a lot of there's a movement to do more complex PCI, CTOs, the CHIP program.
Correct.
But one thing we have to be careful is the experience and the volume of the operator matter. I'm always concerned when we compare data from large randomized trial where there's a strong interaction by site or by operator. And I just want to see is for the left main PCI, we have such a volume and experience impact of the operator on the outcome. And in light of Excel and Noble that will be presented in this meeting at TCT this year, I think that was my idea to show is experience and volume of the operator matters when we talk about left main PCI, which is not trivial intervention.
Right. And you were interested in defining a high volume operator how?
Yeah. So it's always depending of what cohort you take, right? What population.
Yeah.
Zubo, the cohort in China is one hospital, which is a mega center where you have 25 cardiologists that are there for a long time, some for a few years, some for a long time. And they do a lot of cases, a lot of volume. So we define the experience of the operator by tertile of experience and volume. So first tertile, second tertile, and third tertile to have a kind of a dose response or a gradient by itself. We also define the operator experience based on the fact if one operator was doing 15 PCI of the left main per year or less. That's a lot, okay? Because right now, I think in the United States, is the average number of PCI by itself, not only left main, but PCIs, I think is like around 25 or something like that. So that's a special place, but if we see a gradient of or a magnitude of impact, it's going to be there everywhere. So we define this, and actually roughly 25% of the operator of this center, of the 25 operator, were high experience, high volume. We're doing more than 15 left main per year for at least 3 years. And we found that actually, it was shocking what we found actually, because despite being in a high volume place where these guys are doing 300, 400 PCR years, and the high experience operator do 500, 600, there's a strong gradient with at 30 days and 3 years, a decrease of fourfold in mortality, in cardiac death actually. So a fourfold decrease in cardiac death when you're treated by an experienced operator, high volume operator performing a lot of procedure despite doing more complex cases, despite implanting most of the time two-stent strategy, and despite doing higher syntax score. So I think that speaks by itself, and I think we should take these data very seriously because I think patients deserve the best of outcome that we could offer to them. And we have to be honest with the patient, with ourselves, if we really want to push PCI forward and do more complex cases. We have to be honest with ourselves, and if you don't do a lot of cases, at least bring a guy who's doing a lot of cases, and now we will be able to really say, well, yes, against medical therapy, against CABG, this is where PCI stand. So that was the motivation of this paper, is to show that when you do a lot of cases and you do it well for a long time, you save life for patient, and sometimes the doctor is more thrombogenic than the stent or than the patient, so that's important.
I don't know if you've seen it yet, but in an accompanying editorial, Ralph Brindis and Gregory Damer noted a JAMA paper by Anna Reisman, who's describing her experience as a patient, and the piece was titled, "How many have you done?" Mm-hmm. And perhaps this is a question we should be asking ourselves before every unprotected left main PCI procedure.
I think that's a fair question. I think we should not have 15 or more PCI left main. That's a little bit too much, but per institution, we always have a guy, an operator that is more experienced. And so when it comes to very complex PCI, CTOs, left main bifurcation, these cases are not forgiven. There's a lot of complication that could be lethal. You can perforate, you can have tamponade, if you have thrombose of the left main, this is most of the time lethal, deadly. So I think that's the goal. So if someone do 5 or 6 left main per year, to do this with a guy who's doing 50 or 60 bifurcation a year, not only left main, but bifurcation, and he's mastering the technique of bifurcation, I think the patient will benefit of that. And I think this is where we should be in 2016 and for moving forward with PCI technique.
Well, this is in the October 24th issue of JACC Interventions, so please see this particular paper. And for CardioSource World News, I'm Executive Editor Rick McGuire.